We're really fortunate to have Angela McInnes talk to us today about the very important role of our transplant coordinators in patient management before and after transplant. Angela has had a long and productive career in in specialist donor coordination and works for Donate Life Queensland, which is co-located on this campus. Thank you very much.
Thank you. Yeah, I think my talk will lead on from several talks here today. So I'm talking about what we do at Donate Life as far as when we're working up a donor for donor screening, looking at risk, and then the importance of communication if we do find anything. So investigating risk, when does it begin with us? So right from the referral from an ICU, we're looking at the cause of death and clinical presentation. And this all starts prior to formal consent with a donor family. So we have access here through medical records, pathology, that we can have a look at those donors and just see what actually is happening. And we here in Queensland involve our transplant teams in at medical suitability there, and often our ID physicians as well if need be. That is unique to Queensland, where our transplant teams are part of our medical suitability. If we go ahead, then we go on to formal consent with the family and we start doing a full assessment of our donors. We sort of break it down into a little bit of the historical information about them to current information, being mindful that we can't actually get our history in the first person because the patient is deceased. So we are looking at records, we are seeking families, information, etc. We're very much guided by our transplant society's organ donor suitability, the clinical guidelines around that. So we don't just go off and do what we want. We're sort of following specific guidelines here in Australia. We have we have an electronic donor records where all our information about donors nationally are put into this electronic record. Then we can send it on to our transplanters with the donor information de-identified. And it's just trying to create some sort of national consistency because organs are shared from state to state. Donor organs don't just stay in this state from our donors. They can go anywhere within Australia or New Zealand. And then we break it down even further that we have lots of standard operating procedures that our donor coordinators work on, and particularly this one around the workup and the expectations of the tests that are performed. So we start off, once we have consent, is talking with the family, partners, friends to complete what we call the DRE, the donor risk assessment interview. This interview takes us sometimes a couple of hours, maybe as short as 30 minutes, up to a couple of hours, depending on the family and the person that is going on to donation. We then use, once we have consent, we use further sources like contacting GPs, looking into medical records, contacting the cancer registry and just seeing if they're on there, looking at private pathology and seeking further medical opinions if we need them, like oncologists, dermatologists, ID physicians, etc. Our donor risk assessment interview, this is what it looks like currently. It is under review nationally. And it involves 64 questions. So as I said, it can take somewhere from about 30 minutes to a couple of hours, depending on your family. And it's really important, donor coordinator sitting down, building that rapport with the family and trying to get out as much information that you possibly can about that person. Again, being mindful that, we're getting this secondhand. This is not the person telling us about themselves, it's their family who may know a lot or may know not a lot, friends, etc. We then go on to look at, cause of death, clinical presentation, and do a thorough physical examination of that donor from head to toe, hair, within the hair, we're looking behind ears, absolutely everywhere, to see if there's anything there that of note. We do serology, NAT and COVID testing on all donors. We're really lucky here with our pathology, Queensland Pathology over the Royal, or Pathology Queensland. They provide those tests for us on the night. So we NAT test all our donors for HIV, Hep B and Hep C, and those results are back to us within about 4 hours of them arriving into the lab. Irrespective of what we find in our DRE assessment, we always do prospective NAT tests. Some other states only do them if the patient's identified as high risk, or don't do them at all. That's a NAT. We also COVID tests all donors with a nasopharyngeal swab and an ET aspirate, and this began back when COVID hit in 2020. And we've had a really good relationship with our labs that we were able to get those results on the night within about 4 hours of sending them. And they're currently under review to whether donors are going to be continued to be COVID tested or not. We do microorganism sampling of the urine, blood cultures and ET aspirates. And I sort of was asked to have a look at what we do TB, probably related to the last talk. We go on, if we identify donors to be at risk of tuberculosis, to do some TB testing. All that information, like I said, goes into our electronic donor record for transmission to our surgeons and physicians of the transplant groups. Samantha touched on our increased viral risk donors, and together, once we put together our DRE and all our information, we're talking with our transplanters and identifying those donors that we consider increased risk for HIV, Hep B and Hep C infections. And we then track them as far as further results related to this chart. To note, I suppose when I did start as a donor coordinator many years ago, the use of a Hep B or a Hep C positive donor was just, as soon as we got those results, donation was over and done with, and we stopped. And even, HIV sat in our TSANZ guidelines and the absolute contraindication to donation, and there has been reported case of a HIV positive donor donating an organ into a HIV positive recipient here in Australia of recent times. So even that's not stopping us. Tuberculosis. So when there's some specific questions within the AusDRE that relate to exposure to tuberculosis and possible risk. If we have a patient, a donor, that the family identify yes to one of those questions, we actually have to go on and do some further TB assessment and donor screening. So we developed this form together with the help of our kidney transplant unit and ID specialists here at the PA. So when we identify this, a patient as answering yes to one of those 4 questions, we then have to seek a CT scan or a chest x-ray and ask an ID physician or a radiologist to report on that for us, looking for evidence of TB. And then it activates us actually performing quantiferin gold testing and a urine and sputum ABF. If anybody's ever seen our office here at the PA, we have a massive big whiteboard that we put absolutely every donor on, and we put absolutely every test that we take, blood, sputum, urine, and the tracking time, and they don't remove from there until we've got all those results back, and then we rub them off transmit them out and speak with our physicians and surgeons on return of all those results. And like our urine and sputum can be out to 8-10 weeks before that comes back. So once we've provided all of this information, our transplant teams each determine the suitability of that donor organ, and then whether we're going to go ahead with transplant there. It's then that we, as the donor coordinators, set up the donor retrieval surgery, and we go to retrieval surgery once we have recipients for those organs. So in the event of when we actually do get some sort of potential or a donor-derived transmission, yes, it's rare, but the response that we must have is really, really important, I guess, to prevent any further risk to other recipients. So in the case of that patient just recently, the call did come from the physician that the lung patient had a potential donor-derived TB infection, just notifying the donation agency, because that lung unit didn't know where any of the other recipients around potentially Australia were. Our Donate Life agency were the ones that knew that information. So we very heavily rely on the transplant centres, actually, if they do find something in their recipients, notifying the donation agency that this has happened, so that then we're able to talk to the centres where the other recipients from that donor are. Our policy here in Queensland is if we get any positive results, we must make a phone call to all the transplant units and let them know that we have a positive TB, potential donor-derived TB, a blood culture that's positive and what it is, and then we send the results via the EDR, which is like an email transmission of what those results actually are. I was also asked to talk about what we actually do further to that. So if there is any donor-derived or any adverse events that occur, the clinical management and investigation within organ donation occurs at the hospital and the state level. But in Australia, we have the vigilance and surveillance system for organ donation and transplantation, which is a centrally located system for reporting serious adverse events or reactions. The purpose is so that there's one central location looking at them with a group of physicians, surgeons, donation specialists, ID physicians, etc., who can look at all the reports that are coming in and see if there's anything that's sort of emerging, or there's recommendations that should go back out into the donation and transplant sectors. And this is managed by the Australian Organ and Tissue Authority. Oh, yeah. Good, thank you.
Thank you so much, Angela.